what is the best type of exercise for weight loss? I have the answer. The answer is tell me if this sounds familiar. You've tried to lose weight dozens of times and it has not worked. But still, your doctor talks for the entire appointment about your weight. You leave the appointment feeling upset. If you have ever felt this way, this video is for you. Hello, frenemas, it's me, Dr. Jake. I'm a gay doctor, and I'm so happy that you showed up here for your daily injection of queer-ass medicine. This video, though, is not medical advice and is a little bit less queer than usual. But, you know, it's still me. I'm still gay. That hasn't changed. So let's jump right in. The English word... Can't even get through that one sentence when I started the video. Wow. The English language has a lot of words to describe weight. Some of them nice and some of them not so nice. Obese, overweight, rail thin,
anorexic, plump, bony, skinny, slim, slender, flabby, beefy, stout, buxom, curvy, corpulent.
Okay, that was actually a lot. Sorry. Moving on. So it should be of no surprise with all of these words that people fixate on their weight. And medicine actually has a lot to say about weight, and more on that in a little bit. And if you've made it this far in the video, please take a moment to subscribe to my channel and click the like button on this video. It really helps my channel grow and it helps me get my message out to more people. We as doctors do a terrible job informing people of what we do and don't know. And perhaps more importantly, we're really bad at helping people realize why it matters. Why? Why does it matter? I'm dumb. Let's get real. This video is probably not going to help you lose or gain weight. Sorry about it. I hope though that it helps provide you with information about how weight affects health. I also hope it gives you insight into why your doctor is being a dick about your weight. Now, in case you've never heard of it, the health at every size movement is big, and it's actually a great movement. The health at every size movement essentially says that the number on the scale is not the most important thing. Your habits and other measurements of your health are far more important than your weight. Oh, God, phone, why do you ring right during the thing? Perhaps more importantly, it celebrates every size body as a potentially healthy body. And overall, I agree with these core tenets. At its core, the health at every size movement is amazing. It's body positivity. It's acknowledging that people deserve love. They deserve support. They deserve happiness no matter what their weight is. Kind of hard for me to disagree with that one. If you don't feel that everyone deserves love, then that's probably a personal problem. The health at every size movement encourages you to look not only at others, but also at yourself with kindness. Exactly what we need in the world. Unfortunately, the health at every... Is there a cat? Hi. Unfortunately, the health at every size movement is often misinterpreted to mean that your weight does not affect your health. That health at 500 pounds is the same as health at 160 pounds is the same as health at 60 pounds. And of course, there are people who weigh more or less than what's recommended and they feel just fine. Also, some medical conditions profoundly affect weight, like hyperthyroidism. That's not what we're talking about. Even in someone with pristine cholesterol and hormone levels, there is a difference between two people that weigh different amounts. What that means, though, isn't always clear, even to doctors. Oh, she's gone. But before I talk more about that, let's get an important definition out of the way. I want to talk about BMI. Doctors use this measurement to compare someone's weight to their height, and then they subsequently use that BMI number to compare people to each other. Not like this person's fatter than this person, but rather, how will the proportion of your weight to your height affect your health? We do this because a person who is taller has more room to spread out their weight, so to speak. Well, actually, just literally. That's a literal thing. You have more height to spread. Okay, I can stop anytime I want. Wow. For the math nerds out there, we take your weight in kilograms and divide it by your height in meters squared. Currently, we define overweight as a BMI over 25 and obese as a BMI over 30. We also have a classification called morbidly obese, which is a BMI greater than 40. All that the term morbidly obese means is that you have a BMI that puts you at extremely high risk for other morbidities, hence morbidly obese. Also, while this video is about obesity, being underweight also has significant health risks, so comment below if you want to see another video about the risks of being underweight. So let me take you through the evidence that has helped me to shape my views as a doctor about weight. I guess I better jazz it up a little, huh? I can raise 2 eyebrows at once. I can't do one. Whoa. Am I doing it? I'm just winking. These papers are taken from the Framingham Study. Congress funded the Framingham Study in Framingham, Massachusetts. The study started in 1948, and it is still ongoing. They basically have followed a buttload of people forever and looked at their risk of heart disease, and now other types of disease, but heart disease was the primary thing they were looking at in the beginning of the study. So for this first paper, let's turn back the clock to 1967. Over 5,000 participants were studied. They were randomly selected residents of the city of Framingham, Massachusetts, greater than 25 years old. They were all examined for 14 years. The scientists in the study didn't do any kind of experiment. They didn't intervene to try to get people to change their lives. They just observed them and did tests and looked at their health. And of course, in this study, they used BMI as a measure and a more simplified version. As I mentioned earlier, using BMI instead of just absolute weight allows scientists to compare apples to apples. They don't want to compare tall people to short people who weigh the same amount. They want to compare people who are proportionally the same size. And this study did use the word large in it. That was their actual descriptor. They were like, these people are large. But it is what the study authors used in their paper, so I'm kind of stuck here. Then, to make sure that they were actually looking at the impact of weight, the scientists for this study looked at other factors. They took obese people who had normal cholesterol and blood pressure levels, and they compared them directly to normal weighted people who had normal cholesterol and blood pressure levels. Then they did the same thing for the 2 groups that had high blood pressure and high cholesterol. They compared those 2 groups. So basically just isolating out different factors that we already know cause heart disease to make sure that weight is really the thing that we're looking at, or specifically BMI is really the thing that we're looking at. And as for the results, a couple of things stood out to me. Number one, while you'll notice that the larger people in this study had more heart attacks, that relationship was not statistically significant. In other words, the difference was not high enough for scientists to definitively say that larger people are at more risk of a heart attack. However, those who were larger did have an increased risk of a disease called angina. Angina. They also had an increased risk of sudden death. Angina is a disease where your heart is not getting enough oxygen. Because of this, your heart cells experience stress. Most commonly, that stress leads to chest pain. Usually that pain is on the left side of the chest. People with angina can also get shortness of breath when their heart isn't getting enough oxygen. And actually it can present in a bunch of different ways. Women have different presentations, but that's definitely a topic for another video because I could talk about angina for hours. But long story short, larger people are at higher risk for angina. And yes, I'm going to say angina instead of angina because it sounds like vagina. Angina. Is this thing on? Vagina. What if your name were Gina and you had angina? Would you call it angina? I can stop telling bad jokes anytime I want because I'm not an addict. Vagina. Now, I need to mention another thing about this study, and that's the reason I keep saying the word risk. Notice that I'm not saying that being large causes heart attacks or angina or sudden death. I'm saying that being large causes an increased risk of having these things. And maybe it's a touch mansplaining, because you guys probably know what the word risk means, but I'm gonna explain it anyway, because that's literally my job. Risk is, at its simplest, your chance of having something happen to you based on what other people with your characteristics have previously experienced. So for example, if you have bad balance, that will put you at risk of having a fall. However, you can have a fall that's not due to the fact that you were off balance. Someone can push you. They can like slam your head into a wall or something and then you fall. Whatever. The point is your bad balance isn't necessarily causing the fall. So what I'm saying is, in this study, they cannot say that a higher BMI caused sudden death or caused angina. Remember Angina? Remember her? I'm gonna change my name to Gina. However, as humans, we make conclusions based on the data we have, and the scientists in this study had interesting thoughts. So to understand that, let's just first talk about angina. Now, angina, not having enough oxygen going to your heart, that can happen for a couple of reasons. Number one, you can be doing some strenuous activity like running or picking up your cat off the ground. Where are my cats? Okay, I don't know. In normal people, the body compensates for this increased need for oxygen. But if there's some sort of blockage in the arteries, your body might not be able to compensate. You might not be able to pump more blood because your heart just isn't getting enough oxygen to do it. And normally in this kind of situation, the angina gets better when you stop doing the inciting activity, when you stop walking, when you sit down, when you take a rest. You know, you could be having sex. That would literally be angina from the vagina. I'm stupid. Anyway, this kind of angina is called stable angina. You can have cholesterol blockages in your arteries, and a little piece of one of those cholesterol plaques can just break off. It just clogs up the little artery just a little bit. That kind of angina does not get better with rest and actually wasn't caused by activity in the first place. It can happen while you're just resting. We call that kind of angina unstable angina. It's unstable, by the way, because you need immediate medical intervention for it. But anyway, that's not really a part of this video. We're not talking about interventions for angina, so we're moving on. Backing up a little bit, the most compelling potential reason that larger people develop angina is this. Larger people require more energy to move, to breathe, to do anything. Thus, they need more oxygen to help create that energy. The blood is what carries the oxygen to the tissues, and the heart needs more oxygen to pump that extra blood. Therefore, because the heart requires more oxygen in a larger person, they are less likely to be able to compensate when doing some sort of strenuous task. They also still need that same amount of oxygen when one of those little plaques comes loose and clogs up an artery. So of course, they followed up that original paper like a million times. Because, you know, we can't just take a paper from 1967 and then never follow it up. That means that you don't learn anything. They repeated it in 1983 with a different cohort, and then again in 2000 with a different cohort. And by the way, all of these papers are linked in the description, so if you want to check them out for yourself, I strongly encourage that. Don't just take my word for it. In any case, they didn't just do the same study again. They actually said, hey, maybe there are more factors that are actually contributing to these problems that we haven't looked at yet. So they controlled for more factors like age and diabetes and smoking status. They were trying to prove those prior results wrong so they could say, hey, it's not just weight. There are other things that you should focus on instead before you even tackle weight at all. I mean, maybe there was something else we missed that was actually impacting those results. Unfortunately, that did not work out. They found once again that obesity increases risk for coronary artery disease, so a heart attack or angina. I said angina again. Suck it. They also found, unfortunately, that obesity in and of itself increases the risk of stroke. And just to clarify once again, will everyone who is obese have a heart attack or stroke? No. No, they will not. That's not a thing. It's not everyone. It's risk. You're at higher risk. They're more likely to develop these medical problems, and obesity is an inciting factor. It's something that makes you more likely to have a heart attack or stroke. They also looked at diabetes. If you're obese, you're at increased risk of diabetes as well. But it's risk. It's not 100%. The whole point is they can say you're just more likely than someone who is non-obese to get these conditions. But as I mentioned before, this does not mean that obesity is causing heart disease or stroke. It's not an experiment. It could be that heart disease in and of itself causes obesity. Or perhaps there's a third unknown mechanism that's literally causing both obesity and heart disease and stroke and all of the other things. We don't know. We have to look at it. That's literally what they tried to do in this study, but there are always more factors, right? We just can't know because observational studies do not tell you what causes what. They just tell you what correlates with what is related to what. Observational studies cannot prove causation. They cannot, never. Which, of course, leads us to the next question. How do we actually figure out if obesity is causing heart disease? Now, obviously, we can't force feed people and make them fat as an experiment. That's hugely unethical, especially if we suspect, which we do, that obesity is a cause of heart disease. What we can do is instead of making people gain weight, we can make them lose weight or give them the tools they need to lose weight and see who does better. Now, in order to talk about the next study, I have to unpack another piece of little minutia because it's kind of important. It's the Framingham Risk Score. Now, as the Framingham Risk Study examined more and more people, they continued to refine all of the factors that can lead to heart disease, not just obesity. Ultimately, they developed the Framingham Risk Score to unify all of these factors and give people a better idea of their overall risk. This score basically just gives you your risk of having a heart attack or stroke. Open up a browser window and do this with me. Framingham Risk Score Calculator. Go to MDCalc, go to this one. This one's better. You'll see that you can basically plug in a bunch of factors about a patient and then figure out their risk of heart attack over the next 10 years. So I'm gonna plug in a 55-year-old male. He's gonna be a non-smoker, total cholesterol of 250, that's high. HDL cholesterol of 50, a systolic blood pressure of 120. And now, blood pressure being treated with medicines? No. This person has an 8.3% risk over the next 10 years of developing a heart attack or death. So really cool tool, and I suggest you plug yourself into this calculator as well. I find it really interesting. Obesity actually isn't on here. They only use other factors. I can't really explain that. Maybe that's another thing for another video, but obesity isn't on here. Back to me. Hello. Now, the reason I wanted to explain that is that many times studies will use the Framingham Risk Score as a way of characterizing risk for heart disease. They'll also use it as a measure for how much they've decreased the risk of heart disease, particularly in weight loss studies. So moving ahead to the study that I want to talk about, in 2017, they published a study that actually looked at weight loss, and this one was a meta-analysis. A meta-analysis basically takes a bunch of other studies and looks at all of them and comes to a big conclusion based on all of them. They looked at 54 randomized control trials, so actual experimental studies. And in these studies, the participants were put into weight loss programs, medical weight loss programs, where they were monitored by doctors while they were doing the weight loss programs to decrease food intake and lose weight. So basically, the way these studies worked is they put half of the participants into a group where they got weight loss help and half of the participants into a group where they did not. And while some of the studies may have had exercise components, this meta-analysis specifically looked at studies that did nutritional counseling. So the results are actually quite robust. First, they found that people who were put into these weight loss programs were 18% less likely to die prematurely. However, few of these studies actually discussed heart disease. So while there was less heart disease in the weight loss groups, the scientists couldn't specifically make a determination as to whether weight loss decreased heart disease. Just for fun though, they did look at cancer rates, and rates of cancer were not really changed based on whether you lost weight. One thing that's important to note though is that they used a low-fat diet in almost every single study that this meta-analysis looked at. So weight loss itself might not be the only factor at play here. Maybe reducing fat in the diet had some effect on mortality. We can't really know. So the prior study used nutritional counseling to help people lose weight, but this next one used bariatric surgery or weight loss surgery to help people lose weight. This was another randomized control trial, an experiment with over 4,000 participants. Half of them underwent weight loss surgery and the other half didn't. There are a lot of different criteria that can qualify you for bariatric surgery, but essentially, you either have to be obese with a specific BMI, or you have to be obese with a lower BMI and have some sort of complication of obesity. All of the subjects in this study were eligible. The results were actually pretty definitive. Bariatric surgery resulted in fewer deaths from heart disease. It also resulted in a lower number of heart attacks and strokes. About 20% less, in fact. That's a big number. Bariatric surgery for people who are eligible saves lives. Now, I have focused an awful lot about being overweight and obese in this video. Lest you think I'm just being weightist against fat people, that is not the case. Being underweight is also unhealthy. There are plenty of studies that also talk about that, so just leave a comment if you want me to make another video about that. But back to the topic at hand, what does this mean for our average person who is concerned about their weight? Well, here is my personal and professional take on this. First, if your BMI is 25 or below, Medically, you do not need to lose weight. Everyone has different weight goals and wants to look a certain way, but medically, I can't recommend that you lose weight. Once you're at a BMI below 25, you are healthy. From a weight perspective anyway. Of course, that could be different with different diseases. And again, I can't speak to like every single person. Certain people need to be overweight. In fact, being overweight can have some benefits, especially later in life, because you have more reserve in case you get sick. Your weight loss is just not my business if your BMI is less than 25. Unless you lose too much, in which case we gotta talk. But moving on. Second, if your BMI is 25 to 30, you technically fall into the overweight category. And medically, I don't really have any advice for you beyond stay out of the obese category. That's it. And third, if you are obese, you are definitely at higher risk of heart disease and stroke, as well as premature death. If you came to my clinic, I would probably discuss your weight with you and figure out if there's anything we can change to help you lose weight. That being said, this is not a 100% scenario. There are people who have more muscle than fat, and they're actually okay with a BMI greater than 30. It's not absolute, just based on the data that we have and the risk that being obese causes. But there's something else that we need to talk about that a lot of doctors miss. It's not as simple as saying you need to lose weight. That doesn't work. You can't just tell people you gotta lose weight and then leave it there. Number one, weight is a sensitive topic for a lot of people, and it causes a lot of strife and anxiety. When talking about weight with a doctor, a lot of people feel attacked, and that's valid. People don't choose their weight. They eat what they want because eating feels good. Eating is necessary. You have to eat to live. If you don't eat, you'll starve. That's it. You gotta eat. And in medicine, we have many jobs. Of course, one important job that we have, which is the job people generally think about us for, is keeping people healthy and making sure they don't get diseases and making sure that their diseases are controlled and that they live long lives, that they're not prematurely killed by a disease. But another important job that we have is to actually make people's lives better. And longer isn't necessarily better. So for many people, the process of losing weight is stressful. And when it doesn't work, it makes them feel like a failure. And family members and friends make people feel terrible about failed weight loss too. And then add to that the presence of like Instagram thirst traps. It's an attack on your mental health. And here's where I go off the rails in relation to my medical colleagues. If trying to lose weight is going to severely impact your mental health, I am not going to push the issue. Weight loss, stopping smoking, any other lifestyle change that I'm trying to promote, it has to be prefaced with an extremely important question. How do you feel about losing weight? How do you feel about quitting smoking? How do you feel about quitting bad jokes? I'm going to continue telling bad jokes until the day that I die. Anyway, if I'm going to convince you to stop doing anything, I have to have your buy-in first. The benefit that you get has to be greater than the benefit that you'll get from not doing it. And this next section is for the doctors out there too. Once that discussion about risk is done, if you're still not at a point where you're ready to make a change, your doctor needs to back off. Back off. Yes, they will probably want to talk about risk again next time, and that's okay. That's literally our jobs. And sometimes doctors are actually paid more to do that. That's literally a thing that we have to document in our documentation notes thingies. I hate it. But remember, our job as doctors is not to bully you into saying yes. It's not to force you to do anything. It's to help you understand your own body. And of course, there is a subset of people who will follow your advice to the letter and do whatever you say. But I think that most people want to do things that make them feel good. Most people don't want to feel bad. I don't think that's rocket science. If you make a patient feel uncomfortable by telling them to do something that they don't want to do, there's a good chance that unless they're an argumentative asshole like me, they're gonna say, "Yes, doctor, I'll do it." And then they're not gonna do it because they want to avoid the confrontation with you. And that doesn't only apply to weight loss. It applies to literally anything that you ask a patient to do. The most important example of this is when I try to get patients to take medications. I've seen this a lot with high blood pressure. We recommend a medication, and for whatever reason, the patient doesn't take it. But they don't feel comfortable telling us that they didn't take it. So their blood pressure, of course, is still high at the next visit. And then they lie because they think there's going to be a confrontation if they don't. And then we prescribe more medication for blood pressure, even though they didn't take the first medication. And why would they take another one? They don't need more medication. If they want their blood pressure to go down, they have to take the first medication. And if that's not worth it to them, we need to back the F off. We need to accept their choice that taking medication is not a priority for them, even though they understand why the medication might be beneficial. So similarly, if you tell someone to try to lose weight in a particular way, to modify their diet, or to start doing exercise in a particular way, it is probably not going to work. People can't just go from 0 to 60. It just doesn't work like that. But if you are someone who needs to lose weight and it's really difficult for you and it's bothering you, I do have suggestions. Small changes. Small. Are you drinking 3 cans of sugary soda every day in addition to what you're eating? Try going down to 2. Don't try to change your other eating habits, just small changes. Go down to 2 cans of soda a day. If that works for you for a month, try to go down to 1. And then in another month, go down to 0. Okay, another example. Are you sitting around all day and getting 0 exercise? Let me tell you what I wouldn't suggest. I wouldn't suggest that you start going to the gym 3 times a week. That is completely unrealistic, and it's just gonna make you hate me. I also wouldn't recommend that you start running 10 miles a week. Running is hard. Here's what I might recommend. Start going out on a walk once per week. Gradually increase the number of times per week that you walk until you're able to walk every day. So in a month, start walking twice a week. And a question that I get a lot that I'm sure you're wondering about is, what is the best type of exercise for weight loss? I have the answer. The answer is whatever exercise you're actually going to do. It doesn't matter what the best kind of exercise is if you're literally not going to do it. And perhaps more importantly, circling back to the health at every size movement, you deserve to feel happy about yourself. Your mental health is far more important than a number on the scale. Living well is as important as living longer. And if your doctor, nurse practitioner, PA isn't making an effort to understand your perspective, they don't deserve to have you as a patient. Doctors absolutely deserve your respect, but that respect has to go both ways. You deserve sensitive, empowering, and personalized healthcare. Don't let anyone tell you otherwise. So let me just summarize what I talked about. Number 1, obesity has been shown, even if you have no other health problems, to be an issue for your health. Number 2, losing weight, either through a nutrition and exercise program or through bariatric surgery, can increase your health markedly. Again, under the supervision of a doctor and if you meet the criteria for it. Number 3, your weight is only one aspect of your health. Your mental health is equally or maybe even more important than your weight. And 4, your doctors need to be sensitive to your needs when making recommendations. That way you can be comfortable being honest with your doctor. And that's it. Thanks for watching, and I will see you in the next one. Cholesterol blockages in the arteries and veins. I don't know why it's not working. My mouth doesn't work. You can have Okay, video's over, guys. I can't do it. Will everyone who is, oh my God, half of the participants,